Good evening, everyone. My name is Jasmine, and today I'll be talking to you a little bit about my research topic, which is social determinants of health interactions and its effects on overall survival in glioblastoma patients. So a little bit of an agenda so you know what I'm going to be bringing you into. I'll be talking about the background of my diagnosis, as well as some research gaps, which I will be trying to answer with my research question. From there, I will take you through my methods and data collection, followed by my analysis and results. And from there, we'll delve into the implications of my findings, some limitations, and what we can do in the future. So first of all, what is a glioblastoma? Glioblastoma multiforme, or GBMs, is an aggressive and malignant type of brain tumor. Its prognosis is quite low, and it's actually very low survival time. So it accounts for around 50% of all malignant brain tumors and around 15% of all primary brain tumors. Now, primary brain tumors aren't quite common. They're about 1.4% of all tumors in the US, but the incidence is around 3.2 cases per 100,000, and this incidence case can actually go up for white males. Some common treatment techniques include surgery, chemotherapy, and radiation, and more often than not, a combination of two or more of the above. So due to the aggressive nature of this disease, recent research have been popping up with research ideas focusing on the quality of life for patients. Which brings me to my second topic, which is social determinants of health, or SDOH. Social determinants of health is a little bit of an umbrella term describing all of the different factors that make up a person that can affect their health care. Some common examples that you might know is a person's sex or race, but there's a lot more, which is why I'll be using the Progress Plus criteria to easily put them into categories that you might understand. Examples are going to be place of residence, race and ethnicity, occupation, gender and sex, religion, education, social economic status, and social capital, as well as any other factors that are not included in the acronyms. With this, I'll be talking about how do these social determinants of health affect one's health care. When you think about healthcare, you think about going to the ER, you think about going to the doctors, you think about getting your annual health checkup. However, some people might not have that easy healthcare access that you might have. Some barriers include entry. Can they afford insurance? Can they afford healthcare? Do they even want to go get healthcare? 2 is structural. Is there a healthcare clinic near them? Can they get to that clinic? And if they're there, which is the third barrier, which is providers. Do they trust their provider? Can they talk to the providers? And do they share a common background? So with this, a little bit of a previous literature that I did doing a systematic review is that a lot of previous literature focuses on primary brain tumors altogether, focusing on both malignant and benign tumors. Secondary, a lot of the studies focuses on social determinants of health individually and by itself. This is why I would like to focus on social determinants of health interactions, which brings me to my research question. How do the interactions between social determinants of health affect overall survival and 90-day mortality in glioblastoma patients? Secondary question is, which social determinants of health factor will have the biggest weight in these interactions? My hypothesis is that there is going to be a difference when looking at solo interactions as well as the interaction between combinations, and that financial-based social determinants of health will have more weight when taken into consideration. How I went about this was that I went through the UCSD Epic Healthcare database, and from all of the patients that I was pulling out was from the UCSD glioma database with over 500 different patients with all kinds of different gliomas. I was able to gather a little over 200 patients with a glioblastoma diagnosis from 2010 to 2024. The reason why I went all the way back to 2010 is because this case incidence is quite low, so there's not many patients overall for this case. Also, I tried to exclude any other types of brain tumors as well as remissions and out-of-country zip codes that the patients might have because it will interfere with me gathering more social determinants of health factors. Overall, my study population had 214 patients with an overall survival of 42 patients still alive and 172 of them deceased. When looking at 90-day mortality, 142 of them were alive still and 72 deceased. My outcome of interest is going to be overall survival in days due to the aggressive nature of this disease, as well as a 90-day mortality. Continuing on with a little bit of data collection and analysis, I used RStudio for all of my analysis, but all of the social determinants of health was collected according to the Progress Plus criteria. I had over around 20 different categories, and from then I kind of helped organize them? I can answer a little bit more after, but to briefly go over, I use zip code to do place of residence, educational status, and socioeconomic status by doing the ADI, which is Area Deprivation Index, as well as educational levels and income by zip. I also was able to group race and ethnicities into easier manageable groups since a lot of groups had sparse numbers. And for insurance types and providers, I split them into either public, private, or uninsured patients. Other factors that were included were also age, tobacco history, and more, but I'll briefly touch upon them later. So like I said, I use analysis using RStudio. I also use a few R packages as seen here. For my overall survival analysis, I use the Kaplan-Meier survival curve for each of the individual factors to see their significance. From then on, I looked at all of the regression models and their p-values to identify which factors was significant to overall survival, and then put them through a Cox proportional hazard model. From then on, I will try to visualize them using a box plot for median overall survival. Moving on, I will also show you my 90-day mortality analysis, which I use a stepwise Cox model to identify the highest predictors. By doing this, I'm going to put all of the different variables that I had just mentioned and use a back and forth step model to identify which is the top 2 factors, which you will see later on. From there, I will also combine it with one factor that wasn't actually quite significant, but in interactions changes a lot. I will visualize this using a forest plot. So first, for my demographics, there is a lot of people and a lot of variables that I collected. So I will briefly kind of go over the main points, which is most of my patients were going to be male, white, and surprisingly, the insurance was quite spread and everything else was quite spread, including medium income being part of the majority. For overall survival, the strongest indicators that came from the Kaplan-Meier and logistic regression models was an insurance type, which had a really low p-value, with public insurance actually having the best overall survival. For income, which had the lowest income being the worst overall survival. ADI and religion, which I won't include in my presentation, but hopefully will target for more future research. For borderline significance, I saw that race actually was very borderline as well, and as well as religion, or not religion, with language. From there here, this is the Kaplan-Meier curve for race. You might see a little bit of anomaly with the Asian, Black, and African American. However, this is due to one patient living for a longer time than the rest. What actually is happening here is that white and Mexican patients have the best overall survival since their decline over time was less steep than the other groups. This is also for insurance, same thing here with the public insurance. However, you can kind of see a lot more of a clear distinction between uninsured patients, private and public patients. When looking at overall survival with the race and insurance type, you might think that private insurance is going to lead to a better overall survival. However, depending on which group you are in, other different types of insurance might do you better for overall survival. Another interesting thing was that race and income. You might think that high income would be correlated with a better overall survival. However, that's not the case. The best overall survival fell under the median group, followed by high income and low income having the worst overall survival. Next, I'll be talking a little bit about my 90-day mortality rate and how I did my analysis here. Like I mentioned, I did a stepwise model to determine the 2 top variables, which is insurance type and income. After that, I combined them both with the race. And from here, you kind of see that the hazard ratios kind of changed depending as well. And it shows that there was an increased risk with Asian, Black, Asian Americans for 90-day mortality. Now, if you remember for overall survival, you might think that they had a better survival in total, but their drop-off is a lot stronger in the 90-day. There is also an increase in hazard for both high and low income, as well as non-insured. So this is a little bit of a forest tree to kind of show. The anomalies on the top is due to all of the patients in that group dying under 90 days accordingly. So this is for income and as well as insurance. You can see that it changes depending on the group, so it's not really a pattern that you can follow ahead of time. Some limitations is going to include some missing data. Now I wanted to talk about this missing data because there is a big part of why there's missing data in my database. First, there's going to be barriers to a lot of the healthcare access. UCSD clinic is in the middle of a big city, and therefore patients might not be able to be included in the database that I was using. Also, a lot of elderly patients, which is one of the main groups of this diagnosis, may not even be able to get to the clinic and may not be waiting or may wait till the last minute. Also, since a lot of the patients may not be understanding what the questionnaires asked, I had a lot of NAs or others as included in the social determinants of health factors. This was also a retrospective and observational study, so there was no follow-up that I could do. And like I said, it was limited to a single center and to UCSD and to a previously collected database of patients who were already used in a study. However, I think that my findings were quite interesting and important for our future directions. One, there's obviously an interaction between social determinants of health that can lead to different results depending on what you're looking at. When we looked at overall survival, we thought that public had the best. But then when we looked at 90-day mortality, private was the best. So there's obviously a distinction between them. Also, since that it indicates financial-based variables are very important, this shows that we might need better reach-out programs or expanded public insurance policies. Race might not play a role alone. However, when looking at them combined with other interactions, it shows that there might be a little bit of a systematic bias at play that we may not be aware of. For future directions, I think that future research can focus on each group individually, so things such as one group of a race or one community could be handy and increase sample sizes. We can also be reaching out to communities who are underrepresented and get their thoughts on this as well. We can also include other social determinants of health, such as mental health factors and family backgrounds. We can also understand how health disparities are caused and reduce the negative effects for everyone. Overall, I hope that this research can help bring us towards a goal of improving quality of life for all patients and ensure optimal healthcare for everyone. Thank you.